Good evening to one and all present here for today's webinar on World Cancer Day, themed United by Unique. We will now begin this webinar. I would like to introduce our speakers for this evening. Our first speaker is Mrs. Umavali S. Topic that ma'am will be presenting on is early detection and screening, nursing perspectives and best practices. Our second speaker for this evening is Dr. Puvaneshwari Kanagaraj. Ma'am's topic for this presentation is on barriers and critical issues in the way of cancer care. Our third speaker for this evening is Mr. Karthik Sellappan, and his topic for this evening is supportive care in oncology, managing symptoms, and improving quality of life. Once again, thank you all for being here with us today and supporting us. Our first speaker for this evening is Mrs. Umavali. Mrs. Umavali S. has graduated with Bachelor's from Upasana College of Nursing, Kerala, and MSc in Med-Surg Nursing from Shivagiri Sri Narayana Medical Mission College of Nursing in Kerala, and is currently a PhD scholar under National Consortium for PhD in Nursing. With over 10 years of experience in the field of teaching, ma'am is currently a lecturer at Narayana Hridayalaya College of Nursing, Bangalore. The topic that ma'am will be presenting on this day is early detection and screening, nursing perspectives and best practices. Over to you, ma'am.
So I'm happy and thrilled to be a part of this Nurseslab, especially in this occasion of World Cancer Day. And the topic given to me is early detection and screening, nursing perspectives and best practices. So moving to the topic. So the learning objective for today's class, describe the nursing role in promoting cancer early detection and screening program, identify the evidence-based screening guidelines, apply the best practices like patient education, risk assessment, and intervention to improve the screening adherence among the patients, discuss the barriers to screening and nursing strategies, and evaluate the impact of early detection on survival rate and integrate into routine practice. So before moving into the main core, just briefly tell what is cancer. So it's a generic term for a large group of disease characterized by the uncontrollable growth and spread of abnormal cells that can invade nearby tissues and metastasize to other parts of the body. As you all aware about this, I'm not going much into the causes and all. So India holds the third position worldwide. Then we can make out where are we. So the cancer burden in India, the new cases in 2022 is 1.46 million. New cases in 2024 is 1.56 million and death nearly 8 lakh. And it is projected by 2045, it could be 2.46 million. So our aim is to reduce this burden. So as a nurses, what all we can do? So mapping the silent invasion, top cancer sites and the disease burden. So you see the cancer types, the breast cancer about 27%, cervical cancer around 18 to 20, oral cavity cancer around 13 to 15%, colorectal cancer showing rapid increase in the urban areas, oral and lung cancer around 10 to 15%, esophageal that peaks in the northeastern state like Mizoram, head and neck tumors that is also increase in. And the characteristics, when we compare about men and women, the incidence of new cases among women is 51.1 and men is 48.9%. And the top cancers among the female is breast cancer, cervix, and ovarian. Compared to the men, they have more of this oral cavity, pharynx, lungs, and prostate. To compare the mortality, the women has 45% and men is having 55%. But when we take the cases, the new cases are reported more from the women's side, but the mortality is more among the men. So the prevention pyramid, building a cancer defense layer by layer. So why I'm talking about the prevention is our early detection and screening comes under a part of this preventive aspect. So as we all know, there is primordial, primary, secondary, tertiary, and quaternary prevention. So moving to the primary, implementing the community-wide policies where we are planning to just give health education to people and avoid all those risk factors. Moving to the secondary, and here conducting early screenings. So what topic we are going to discussed today falls under the secondary prevention, that is early screening and detection. Thus, we can early prevent the most complications among the patients. So, what is early detection and screening? So, early detection in cancer refers to identifying the diseases at its initial stages, either through screening a symptomatic individual or promptly diagnosing the symptomatic patient. Either we need to do early detection or already detected, that has to be go for a consultation and further management. So, what is this early diagnosis? So, it has two components: increase awareness and improved access. So the early diagnosis, for that the patient must have a knowledge that what could be the signs and symptoms of a cancer, and the people must have the early access towards that affordable diagnosis and treatment. This too will act as the early diagnosis component. So what is screening? So according to WHO, screening is defined as the cancer screening as a systematic process to detect cancer early in asymptomatic people, aiming to reduce the mortality through timely interventions. So upcoming slides we will see how this will help. The early detection and screening will help to reduce the mortality. And the common screening programs happening in India are breast cancer screening, visual inspection with acetic acid for the cervical cancer, and breast cancer screenings. So why it is important to go for a early detection of screening or cancer? So the early detection can reduce 90% of mortalities and 30% of advanced stages as well we can reduce. So why early detection is important? The disease detected at the early stage produces better results on the treatment and even cure. Advanced diseases shows poor result on the treatment. As we all know, we are seeing the patients who come to the hospital with the later stage of the disease. Why? Because they are not aware about the early signs and symptoms. They were not even aware that they have to go for a better screening processes. So the advanced disease leads to the financial and psychological burden as well to the patients. So when we talk about the screening or this early detection of the disease, we cannot miss this caution. That's an important part of this warning signs of cancer. So caution, the expansion, see a change in the bowel or bladder habits. So the patient mostly present with a persistent diarrhea, constipation, blood or urine in the stool. And a sore that does not heal. The patient has a continuous sore which for a long time lasting more than 2 weeks. And unusual bleeding from any part of the body. Mostly the patient with lung disease, we can say cough in the blood or nipple discharge for breast cancer, rectal bleeding. These are unusual bleedings. Teeth thickening of the lump. So breast mass, lymph node swelling or testicular lump, all these are examples for the thickening or lump in the particular body part. An eye for the indigestion or swallowing difficulty, a persistent heartburn, dysphagia, and early satiety. All this could be a symptom of cancer. And obvious change in the wart or mole. So asymmetrical skin, the skin appearing irregular with borders, a color changes on the skin, all this could be a sign of cancer. And N describes the nagging cough or hiatus. So the smoker's cough more than 3 weeks could be a sign of cancer. So that is the introduction for the warning signs of cancer. So why to discuss early detection and screening of breast cancer? So from this data, you can see when the early stage survival rate or detected early, the survival rate is 99% in breast cancer. And regional spread survival rate is 86 to 87%. And distant metastasis 32 to 33. So as you all can see, the earlier the detection, the more the survival rate. This is according to the National Breast Cancer Foundation. The data is taken. So moving to the warning signs of breast cancer, as you all know, you all might be knowing this basic data. So the new lump in the breast or underarm or armpit. So you can see in the first picture, a lump present in the armpit, irritation or dimpling of the breast skin, redness or flaky skin in the nipple area or breast, pulling in of the nipple or pain in the nipple area, nipple discharge other than the breast milk, including blood. So the abnormal discharge from the breast, any change in the size or shape of the breast. All these are the warning signs of breast cancer. So this is also the breast skin look like a orange skin or a pedo orange. So why it is important? The breast cancer screening procedure. So there are mostly available procedures are a clinical breast examination, breast self-examination and mammography. So this and all already we are teaching to the patient. So when to do the breast self-examination? So as a nurse, you all can teach this to the patient. Not only the patient, any group come under a risk or aged, you can take this procedure. So the best time to do the BSc is 2 to 3 days after the periods ends, because otherwise the breast will be already tender. So if we palpate the breast, they may feel there is a lump in the breast. So the best time is to 2 to 3 days after the menstrual cycle. And we will ask the patient to pick a particular date every month to do this, a birthday date, or let them fix a date every month to go for this examination. So the steps, step one, in front of the mirror they can do in the shower and the lying down position. So in front of the mirror, as you all know, ask the patient raise the arm above or lower the arms and press them firmly against the hip on arm and tighten the chest muscles. Then check for the size, shape of the breast. So expect it to be the normal size and shape, both the side, the right and left. Appearance of the skin around the nipple and any discharge, abnormal discharge from the nipple. In the shower, raise the right arm above the head and soap left the hand, and using the middle three fingers, the patient of the left hand, the patient can check the breast. Press firmly, starting from the edge of the breast. Feel around your breast, going inward. So ask the patient not to do it in a rushy time. They have to do it very calm in a round manner so that they can identify any lump. If they have any pain during that procedure also, they can inform. And they can also move the finger up and down vertically and rowwise also. So repeat these steps using the right hand to check the left breast. So vice versa, they can repeat for the right as well as left breast. So lying down position, place the pillow under the right shoulder with the right hand under the head. Check the breast as described in the shower position. Same, they have to repeat and check for the lump. So clinical breast examination. So this procedure will be performed by a expert, either by the gynecologist or experienced nurse will be performing this. So that will be taking around 5 to 10 minutes. So this is a gold standard test. The mammogram is a gold standard test to confirm this breast cancers. So what happens here, most of the time the women try to avoid this mammogram because they heard from other people like it is a painful procedure, they compress the breast. So when they apply for or they go for this regular checkup, routine checkup also, when it comes to mammogram, most of the females cross that, thinking that like painful procedure, so they try to avoid this procedure. So the international and national standard for screening the breast cancer. So I have compared this international as well as the Indian standard. How to do this? Follow-up or screening for a females. So the average risk start 40 to 50 years according to this United States Preventive Services Task Force. But at the same time, when we take ICMR, they suggest for 30 to 40 years. Let the patients or the people go for a clinical breast examination or self breast examination. And the primary method, what they follow international is a biennial mammography to up to the age for 74. So biennial means every 2 years they have to go for the mammography. And here in ICMR, CB annual and mammo biennial from age of 40 plus. So the risk is more among Indian females. Maybe they're starting from the age of 40 plus. The frequency for this examination or MRI is biannual according to this US standard, and in Indian standard mammography is referred every 2 years after the 40 plus. And high risk group should go for at the earliest from the 25 to 30 years, and in Indian standard earlier consult if they have any family history of having this kind of cancers or breast cancer, they have to start at the earliest. So here we have an app, Snehida Women's Health. It is developed by two doctors, a couple doctors from Trivandrum. They developed a tool like an app. So you can put your data in the app and you will come to know that your risk of developing a breast cancer. So the basic data what they ask for is the current age at menarche, at age at first birth, the live birth, number of live births, history of breastfeeding, number of first degree relatives with the breast cancer, total number of previous breast biopsies. So with this data, they will calculate a risk number. So with that number, you'll come to know, are you at a risk to develop the breast cancer or not? So this is available online. This HTTP Snehida in risk you can enter. This we can teach to the patient. If they are not willing to come to the clinical also, they can calculate their own risk and come to the OPD after calculating this risk. So the best practices in breast cancer screening, use multi-channel invitation. So the patients or the people who are at age of 40 plus, they may not be willing to come for the all these kind of procedures. So what we can do is we can do an awareness program through the SMS, phone call, email, just a random messages to them that will make them to be aware and ask them to, they can come for this procedures or screening. Engage primary care providers. So the general physician, gynecologist are expected to work with the patient for this early screening. So they may come for any other problem with the gynecologist, but still they can be instructed to go for this kind of screening procedures that can be told by gynecologist or general physician. So year-round awareness campaign. So what happens? So once in a year, you tell them like go for this program. They may forget. They may not turn back to this kind of screening program. So it should be a rotation. So it could be like a every month awareness program, messaging them repeatedly every month. So this may make the people to be more aware about the screening programs. Engage the younger generation because they'll be like very shy to come for all these kind of procedures. So how to engage the younger generation by promoting the breast cancer awareness in school, inspiring the students to advocate for the screening with their family, encouraging their mothers and grandparents to participate. So we can instruct or health education kind of programs can be planned in the schools, instructing them as well as ask the students to go and instruct all the family members who are female to go for the screening programs. Develop resources to help women understand the screening process and potential outcomes. So when we stress about the importance, they may come forward for this procedure. Enhance data accuracy and consistency. Train professionals in artificial intelligence integration. So the work will be done easily when we have this AI-related investigations and screening. Expand the genetic testing access because most of the time the problem happens because of the poor accessibility to the patients. Moving to the cancer cervix. So the early signs of this cancer cervix: abnormal bleeding, unusual discharge from the vagina, bleeding after the sex or intercourse, lower abdominal pain, pain during the sex. So these are the early or warning signs of cervical cancer. So as you all know, the common test to know is there is cervical cancer is the pap smear test. So the other test is visual inspection using acetic acid. So what happens here? The procedure is the patient lies in a lithotomy position. So what the doctor do, they apply 3 to 5% of acetic acid, which is a dilute vinegar, apply evenly on the cotton that will be sprayed over the cervix. So they wait for 1 to 2 minutes of the reaction. So in the picture you can see the first picture is a negative one. So if the second picture appears on the cervix, the patient may be positive for the cervical cancer. So this is a comparison of international and Indian standard. So the target age is 30 to 49 internationally, and Indian standard is 30 to 60 years. And primary method in India is VIA, and the frequency is suggested every 3 to 5 years. And alternatives, HPV, if available, the pap smear is recommended. And the high risk, same, but VIA is a primary. So if the female is a high risk group, then VIA will be the primary test for the women. The best practices in identifying the cervical cancer is HPV vaccination and prevention, knowledge, impart the knowledge regarding the screening program accessibility, screening methods, and population trust, because people must know that we can trust and we can go for a screening method. The method will be right and the results will be good. Learning from the international best practices, that is why I compared and put, because the international standards may not be followed in India. So the better practices can be incorporated with the Indian standards. Moving to the oral cancer. So the early signs of oral cancer: persistent sore, patches in the tongue, chronic pain, swelling in the tongue, hoarseness of the voice, difficulty in opening the mouth. The patient may say that I have pain on both the sides of the jaw, a lump in the neck, difficulty in chewing, unexplained bleeding, loose tooth. So when you know these warning signs, the patient complains this to you, you can better correlate with any disease condition. So the screening test includes the primary test is oral visual examination. So it's a main tool to assess the oral cancer among the patient. And the guidelines in India under Ayushman Bharat, the screen adults 30 plus. So yearly via the health wellness centers, prioritizing tobacco uses, positive findings leads to the biopsy. So 30 plus males or females are expected to do this test, and it is coming under this Ayushman Bharat. Okay, that they go for a wellness clinic, there all the systems will be assessed and can be identified. So this is the international and national standards to screen this oral cancer. So according to WHO, the frequency is expected in case the patient has any suspected mouth ulcers is there which is not healing, then the patient has to go for the oral examination. And NAMS, that is the Indian National Academy of Medical Sciences, that is integrated with the this non-communicable disease program. So they do the regular screening for the patient to identify this cases of oral cancer. Moving to the colorectal cancer, so the most common warning signs are means constipation, diarrhea, blood in stool, narrow stool, unexplained anemia, a tender abdomen or abdominal pain, and unexplained weight loss. These are the common signs of colorectal cancer. And the screening tests involved here are fecal ocultabilis test, flexible sigmoidoscopy, colonoscopy, and CT colonoscopy. So these are recommended screening tests. So when we compare these two groups, like international and Indian standard, so it varies according to WHO FIT, that is fecal um, standards for the fecal immunochemical test is expected to perform annually and colonoscopy every 10 years. And India, it is not standardized yet, case based on the symptom of the patient. This test can be prescribed from the doctor. And the best practices among this cases of this invitation strategy and participation, right? Because the people may not be willing to come and we participate in the screening program. So public awareness campaigns, impact of false positive test in the colorectal cancer screening program. Suppose the patient done a case, done a screening and it came as positive, then further when we do the test, if it comes negative, the patient may think that these tests are very not accurate. So always try to keep the the test is like test all these are giving a proper accurate data. Moving to the liver cancer, most leading cancer, unexplained weight loss, persistent fatigue, mild abdominal pain, and nausea and vomiting, pale stools that can be a typical sign of this, and vital for high risk group. So, what are the routine screening for the high risk group? So, who are the high risk group coming into this? Cirrhosis and hepatitis, chronic hepatitis, cirrhosis, and high risk group. So, all these people come under the high risk group. So, definitely they have to go for the screening with the symptoms. So, the advanced signs of cancer, liver cancer, the patient present with the jaundice, ascites, skin changes or itchy skin, and the fever. So, the standards comparing the national and Indian standard. So this alpha fetoprotein is optional if ultrasound quality is good. So first the basic test will be ultrasound scanning. If any suspect is there, the combined alpha fetoprotein test will be suggested. And in India, the Indian National Association for the Study of the Liver, they recommend for this go for a check every 6 months in case the patient is a target group coming under the cirrhosis or chronic HPV or hepatitis C virus positive people. So moving to the lung cancer, the early symptoms. So the early recognition can improve the survival rate. So it resembles the symptoms like other respiratory illness as like cough or sometimes the mix of blood in the sputum. This may resemble the other illness as well. So it is a painless growth. The tumor may be a painless growth and the patient will have the subtle signs like fatigue, infection, loss of appetite. Sometimes they may not have the cough at all. Okay, so sometimes accidentally the patient may get diagnosed with the problem. So the screening for the lung cancer, the heavy smokers must go for this low density CT scan and non-smokers may benefit from LDCT if exposed to the random family history of lung disease. So the smokers, it is a must. Non-smokers, they don't smoke, but the first hand, second hand, and even third hand smoking may cause this lung cancer to the people. So who are the high risk group coming under this screening are heavy smokers, urban high risk populations, and non smokers who got exposed to this smoking. So, the additional detection methods include bronchoscopy, liquid biopsy, and chest x ray. So, these are some recommended standards. So, the best practices for this cancer improving the accessibility and inclusion in the lung cancer screening programs because smokers may not be willing to come for this kind of procedures as they know they may test positive for this cases. And raising awareness about the lung cancer screening, expanding screening program availability, and implementing new screening programs, develop comprehensive lung cancer screening programs. So the warning signs of skin cancer. So most people know neglect this kind of signs. So this warning signs can be discussed under A, B, C, D, E. So A is asymmetry. One half doesn't match with the other part of this lesion. B border, the edges are irregular, ragged, notched, or blurred. The C, the color varies with the shades of brown, black, red, white, and blue. And the diameter of that particular wound or the skin rash larger than 6 millimeter and is evolving, changes in the size and shape. Normally, if it is not a cancer, it may not change in the size or shape. And non-melanoma, the basic cell carcinoma or squamous cell carcinoma, that open sore that bleeds, pearly or shiny bump, rough, scaly and red patches can be seen. waxy scar like an area with four edges. So generally their edges will be irregular and dome-shaped growth and a wart like a lesion. So these are the common symptoms what we can see the normal skin as well as the cancerous skin. You can have a look on that. So the national and international standards for identifying the skin cancer. So internationally, it is not specified based on the case scenario. They can go for the test, and in India, according to ICMR, it is also not standardized based on the symptom. The patient can go for the further screening method. And coming to the prostate cancer, so the early signs will be difficulty in starting as well as stopping the urination, a weak flow in the urination, pain and burning sensation during the urination. So, what are the signs of this advanced prostate cancer? So, painful ejaculation, erectile dysfunction, persistent pain in the pelvis. So, mostly they avoid thinking that I'm standing for a long time, sitting for a long time. So, these are the symptoms mostly avoided by the patient, and weight loss, fatigue, and bone pain. So, the screening test, you can see the method PSA, prostate specific antigen, is the most commonly used screening method, and digital rectal examination. So the method is used based on the patient's symptom. So the combination yields, the both test yields, if any result, like the patient is positive, then the patient has to go for a biopsy or MRI to confirm the test. The best practices for this prostate cancer: establish a formal prostate cancer screening program. As we talked about this breast cancer, the same way, the even the school children must be taught about how to do the testicular examination. The same can be conveyed to the family members. So leveraging existing healthcare expertise, addressing the limitation and opportunistic screening, enhancing the access to the prostate cancer screening, enhancing access to the prostate screening methods, increasing public awareness. So that is very important part, making it public aware about the signs and symptoms. So what is the role? Here comes the role of yours. So the nurses play a pivotal role in cancer early detection and screening, especially in the resource limited setting like India, where they lead community level efforts to under NPCDCS. So that is a program, national program by Indian healthcare team. So their contributions span education, hands-on screening, referral, advocacy, aligning with Ministry of Health and Family Welfare training modules. So as nurses, you will be undergoing certain courses on this. So and after learning the course, you will be teaching the patients about the warning signs of cancer. So when we take this role of the nurse, we can divide into major headings like education and awareness, direct screening, referral and follow-up, and capacity building. So how they can do all this is that education awareness can be given in the community area, especially the skin cancer, prostate cancer, breast cancer. So they can teach the community people how to identify these problems. And the impact is increased uptake of screening. As we start to teach in the community, people will be willing to come for the screening methods. Direct screening, low cost test, clinical examination. So you can instruct the patient that self breast examination or the free clinical which will be conducted in the community will not have much effect, cost for the procedure. So that can be instructed. And this importance of clinical breast examination, VIA, OVI, and confirm positive cases before the referral. Referral and follow, because once you identify the case in the community, you will be the person who will be referring the case to the next level. And capacity building program, as a nurses, you must be efficient to identify this kind of symptoms, right? So the capacity building programs can be implemented to enhance the nurses' knowledge, and the cervix screening test protocols, mental health pro tools addresses the gaps in the rural India. That's the part where they lack this kind of testing and screening. So the AIMS has a department called AIMS Family Cancer Clinic, where they can go for the repeated test and screening to know if they have already a known case of breast cancer in the family member. They can go for the repeated examinations here. So in India, we have the national program for this prevention and early detection of the cancer. That is India's National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, strong under the National Health Mission. So they act as a resource for identifying the early detection of this problem. So I have brought few research articles which shows that the early detection or the making aware among the people brought out this reduction in this no death mortality rate, because they started to come early and identified the problems and they were treated. So there are few articles which shows the lung cancer reduction mortality, colorectal cancer and reduction in the mortality, breast cancer awareness, cervical cancer reduction, and prostate cancer as well. So these research studies typically shows that the more the awareness or the screening and early detection, that will definitely reduce the mortality rate. This is all about my presentation.
Thank you, ma'am, for your detailed presentation. And most of all, thank you for your time and your efforts for coming here and presenting this webinar with us. We'll move on to the part two of our webinar. That is, I'll be introducing the second speaker for this evening, Dr. Puvaneshwari Kanagaraj. Dr. Puvaneshwari Kanagaraj is currently working as an assistant professor, Department of Medical Surgical Nursing, University of Bisha, Kingdom of Saudi Arabia. Ma'am is a first rank holder, gold medalist, and distinction holder in her BSc, MSc, and PhD nursing. With over 25 years of experience in the field of teaching and research, Ma'am has received the Best Employee Award in Feb 2020 from Narayana Hridyalaya Foundation. She was a resource person for 27 conferences, webinars, and workshops. She is a recognized PhD evaluator and examiner by Rajiv Gandhi University of Health Sciences. Ma'am has also published various paper presentations for Scopus and Web of Science journals. Her topic for today is barriers and critical issues in the way of cancer care. We welcome you once again, ma'am. Over to you.
Thank you, Ms. Tanya and Nurseslab for giving me this opportunity to talk on barriers. I know like it is a late evening, the weekend, everybody will be very tired, but I appreciate all the participants to join today to get some information related to the cancer, because it is a very, very important issue nowadays. To have an awareness. Even the first speaker spoke about what are the diagnostic tests, and now I am going to speak about the barriers. So these are all the aspects which is mostly related with the preventive aspects. So unless we have an awareness, we cannot prevent some major issues. So hope these topics will be beneficial to everyone. I'll be starting the session. So the topic what I have got is barriers and the critical issues in the way of cancer care. So cancer care, like as Ms. Vima has explained, it is starting from primordial prevention and till like tertiary care. So the issue starts from the primordial care itself. So what are the aspects? That's what we are going to see today. A little brief introduction. As we know, cancer is a complex condition. It requires multiple interventions. There are a lot of healthcare professionals are involved over the prolonged period of time because it becomes a chronic problem. It is not just doctors or nurses. It involves many people, even the people that are working in the primary health centers, community health centers, diagnostic department, laboratory department, like multiple people, healthcare professionals are involved in this. And this complexity of healthcare services delivery is really creating a lot of challenges to us, both in the hospital as well as the community setting. Why the word of community comes here is because that is the area where most of the public go to the primary health center or a community health center to get a treatment. But when we are not aware of the situation, when we not aware of the signs and symptoms, or we have a lack of resources in those areas, it is very difficult to direct the patients to the referral hospital. So that is an important concern. And the lack of coordinated care, like whenever we are providing a care to the patients, so sometimes it will be going as a like incoordinated care, fragmented care, and failing to access all the appropriate services. All those things are leading to a insufficient care for the people. So care coordination is mainly it is involving multiple members in the team. They can provide an appropriate care and timely care. That's something very important. When it is coming to a cancer, as we know the different stages of cancer, if we miss the case in stage 1 very quickly, depends upon the type of cancer, it goes to the stage 4 and finally we cannot save the clients. So timely care is something very, very important in cancer. And there are a lot more key elements we have here in coordination of the care, like psychosocial assessment. Because when we hear a word cancer, whether the person related to a healthcare team or they belong to any other profession, everyone gets scared. It is an alarming word for everyone. So once we hear that word, definitely the family gets shattered, the client gets shattered. The psychosocial assessment is very, very important. And we need to have a suitable and timely referral. That's what I told. The patient comes to the hospital, like especially a primary health center, and they say the complaints, and maybe it's unable to identify, or they go to a clinic. They didn't identify, so it takes some time, 1 month, 2 months. After that, when we refer, maybe the patient is entering into the stage 2 or stage 3. So that is like very important. That's why the care coordination is important. It is not just only the oncologist identify. So everyone in the healthcare team should have a basic awareness of cancer signs and symptoms. So we should try to do it a timely referral and information provision. Again, it depends upon the individualized treatment. Each individual, the growth of cancer tissues related to the type of cancer, it may be varying. So the individualized treatment is also important one related to the care coordination. So this is one like a study in 2010, even though it is very old, I just want to put here the barriers. What are the barriers we have in care coordination? The first one is like ineffective team and inadequate resources. These two things are a very important aspect. So inadequate team. So recognizing the health professionals' roles and responsibilities. Every one of us have a specific roles, whether you are working in a primary health center, or you're working in a tertiary care hospital, you are working in specific to the oncology department. We have our own roles. So it's not that everyone will come directly to the oncology department for getting a treatment, or when they have a suspect of cancer, they will just come to any clinic. But based on symptoms, the people who are working in that particular area, they have to refer the client to the like advanced specialty treatment. So that is something very important. Every one of us should know our roles and responsibilities. And transition of care, which is very important. So not just treating the client with the basic medicines, and inadequate communication between the specialist and the primary care area. So that is also another important aspect. So these all comes under an ineffective team and inadequate resources. So like countries like India, we have a lot of inadequacy with the resources, and especially that multidisciplinary team meetings will not be happening, and managing the scarce resources. Like whenever it comes with a cancer, we know like radiotherapy or chemotherapy, these are all very costly medications or costly treatment. So it is a little difficult for the public to get it, and inequitable access to healthcare services. This is also another important barrier. So this was given in a research in 2010, but like when I started exploring more, even in 2025, the same issues we are facing, even after 15 years. So that's what like lot of changes to be happening from the policy level itself. Related to the burden, there are many like detailed burden Dr. Ms. Uma has explained to you. So just a little bit I have put here. So the number of death in cancer in India is like 30% greater than other countries. That's what they say. So that is why it comes under the third category. She said like in the year of 2020 or 25, it is holding a third position. So that is a big no, sad news for us. And India's mortality incidence is also like rising 0.68 compared with 0.38 for high income countries. So their treatment facility or the awareness facility all a little better. So their treatment, their mortality rate is also a little down. And childhood cancer survival, again, it is over 80% in high income countries, but it's very low, like 20% in low income countries. And more than 90% of cervical cancer mortality occurs in low and middle income countries. This is a very sad part, like cervical cancer is the one which can be prevented. So HPV vaccination, when they are taking at the age of 9 years to 15 years, in between there is a 2 doses. So when they have that in the adolescent period itself, it can be preventing 90% of more cancer mortality. That's what they say. But still, it is under a lot of research. But many governments are trying to put a cervical cancer vaccination into the immunization schedule so they can prevent this type of cancers. So this is the main core area, like reasons or factors. What are the reasons or factors which is leading to a poor treatment response? First one is underreporting. Underreporting is a major issue because even when we are taking a cancer registry, the informations are not correct. It is not completely recorded. Most of the informations are missing. So we are not able to get really a correct statistics of it. lack of availability and poor adoptions of early screening. So many early screening techniques, a simple breast self-examination or cervical biopsy, all those cervical pap smear, but we are not doing that. So that is the thing. And late stage advanced identification, definitely it will be leading to a, by the time it is a metastasis and the prognosis is very bad. Low level of awareness in the population, even healthcare workers. We all think like we know because we have studied 4 years of BSc nursing or MSc nursing or PhD nursing, but there are still like lack of awareness related to a cancer. We need to be updated with everything. So again, the healthcare workers, when they are not having an adequate awareness, even it includes community physicians, doctors. So when they are not having an adequate awareness, they are not referring a patient to the other hospitals, referral hospitals. So again, that is the issue. Limited diagnostic facilities locally, like local hospitals, distance to the cancer treatment center. This is a major issues. Maybe in detail we'll see on the next slide. Financial constraints and stigma associated with the diagnosis. Yes, definitely. Finance is a big problem. And when we heard a word cancer itself, the stigma is coming. So even you have a symptoms, you guess or suspect whether it may be a cancer, but people are not coming forward to have a check because they have a stigma. Societal stigma towards cancer is very negative. So with that, no, they don't come forward. So here the major critical issues I have put here, like gender and gender norms and discrimination, patient awareness, fear, barriers for minor population, poverty and socioeconomic status, inequitable access to healthcare, and infrastructure, lack of resource, oncology workforce, and the cost of care, lack of clinical trial, and barriers for vaccination. So these all are the barriers and the issues. So this is what we are just going to see little detail, and how can we manage it? That's what we are going to see. Gender norms and discrimination. So mainly when it comes with the females or women or girls, they always have, there is a discrimination between males and females. So with the cultural and religious contacts, so these children or girls or women, they are very hesitant to tell their problems to their parents or to the husband or to the family member. So with that, they go for a very delayed cancer treatment. And especially stigma with both the cancers, breast cancer and cervical cancer, they feel like very hesitant. Let me not go for even breast cancer is the one which can be treatable at the early stage. I remember one of my faculty, like she was around 60 years. She was working with this when when I was working in Bangalore, and she had a symptoms of breast cancer, but she didn't tell anyone because she was hesitating. When it was identified with the compulsion of family, when she went to hospital, they identified it as a breast cancer. But she is a nurse. She is like she was working as a principal in one of the college. But again, the stigma. So they have a lot of things. So finally, now she's no more. So breast cancer and cervical cancer, and again, it is something feminine oriented like that we feel, and no, not opening up. So that is leading to a reluctant to care. So that is one thing need to be aware of. And women always, they need some approval from the family or a husband or a children. So they feel it is a burden for them like that. So they are just neglecting their care. That is one reason in women. Similar way, men also have their own gender discrimination and societal taboos. If, for example, like for a prostate cancer, Ms. Uma was telling that is initiation of urination is the problem, but they don't reveal it to outside. They will maximum of their capacity. They will like try to hide it. But when it is beyond the limit, when they have a bladder distension like that, then they may come to show to the hospital. So like that, there are cases. Some of them will come and discuss, but many of them are like not willing to discuss about these things like urination issues. So it may be an early stage of a prostate cancer. So quickly they can identify, or they may think it is a problem with their sexual life impotence, like that. So many things they will think, and they are not revealing up. So that is also a concern. So males are also having a discrimination, a similar way what female has. Lack of awareness. gap of knowledge about the risk factors and contribute, which is related to the different type of prevalent cancers, and low health literacy. Even a person who's like highly educated, maybe having a PhD in different disciplines, maybe an engineering or different arts and science, but the health literacy is very low. But nowadays, there is a lot of improvement in the health literacy with the public, but low health literacy is an important like problem related to the cancer management. And misconception. There are so much misconceptions, including like healthcare professionals. Like when we hear a word cancer, we are scared. That itself will reduce the power of that. Psychologically, the person will come down. So cancer is treatable. That feel is not coming very fast. So that fear is so much with a lot of misconceptions and inappropriate belief. So like some people think it is incurable and it is transmissible like that. So those myths also will be having like poor approachability to the screening aspects. And this is one study which was published in 2021, approximately 7,688 population sample. Overall, the knowledge for the women is like only 40.22%. And related to cervical cancer, they say like only 20.3% is screening and 32.68, like they think early marriage is a risk factor for cervical cancer, and 23.0 is the early age of initiation of sexual activity, and 30.75 and 28.6 are like intermenstrual bleeding and foul smelling. These are all the symptoms. Why these factors, like especially the early marriage or initiation of sexual activity? So these all things, when they are aware of it, they can go for even a HPV vaccination. So with that, like in India, our marriage age is like 18 and 21, above 18 and 21. But in Western countries, they are allowed even after 14 years, like they can have a sexual activity like that. So they need to be aware of this cervical cancer, because cervical cancer is a cancer. One of the main reasons is human papilloma virus. So with these vaccinations, this HPV can be like prevented. That virus invasion can be prevented. So which is leading to a cervical cancer. So that's why this is very important. So there are a lot of researches are happening on the cervical cancer related to the awareness. Fear, misinformation, as we know, it's a negative cycle. When we have a fear, automatically our power will come down. So this prevents the person to go for a screening and identification of early symptoms, or delay or avoid the treatment. That is one thing. So once they go for some type of a treatment, like a chemotherapy or anything, people will think their hair will fall, they will lose weight, vomiting. So let me not go for the treatment, because this is the information everyone says when they are under a cancer treatment. So these are all the different informations. When they receive some like misperceptions, they avoid the treatment and care. And embarrassment or like anxiety, because each procedure they have to undergo, maybe a cervical cancer or a bladder cancer. Maybe they are going for an brachytherapy. So they feel very embarrassed every time I should go like this and lie in a hospital, and my privacy is violated like that. So those things can be also a issue. And this is another problem with minority population. Racism is also a factor, like global wise, when we are looking into that. And minority populations, they face a lot of serious barriers, especially to access the healthcare, especially indigenous people. In country like India also, we have a lot of indigenous community. Those are living in a different area. So 6% of the world population, but account for 15% is poor, extremely poor. So they cannot access for any treatment. So they face a lot of worsened health outcomes and poorer health outcomes, because the early access to the treatment is also not there. The continuity of care is also an issue for them. And other factors like higher exposure to poor nutrition, because already they are poor. That is one thing. And substance abuse and some of the high risk factors they may be risk factors they may be using. And refugee population, this is another group of people. When they're moving from one place to another place, they're not like able to get a proper treatment. And cancer screening among a transgender also. That is also a problem. Like they feel like again hesitant. Already transgender is a stigma. So here cancer screening is also a problem for them. Poverty and socioeconomic. As we know, poverty is a very, very important thing because cancer treatment always, it is a high cost treatment. There are public hospitals available, but again, the resources are very lack, so they need to wait for a long time. So poverty always limits their access to the quality cancer care. And mainly, when we are looking into this poverty and socioeconomic, financial is a big burden for them because they may be staying in one place, but they have to transport every day for a chemotherapy or a weekly 2 days or 3 days when they go for a radio or a chemotherapy. They need to move to a different location because the facility is not available in their village. So the transport itself will take a lot of cost. Again, the treatment cost. So like that, those issues they will be facing, and they may be working. They may be the like breadwinner of the family. So when they want to go out of work, again, it's a problem. Their salary will be getting deducted, so they don't want to go and accommodate the screening and treatment, the cost. So there is lack of health insurance in our country, but nowadays people are little aware and started taking a health insurance. But whatever health insurance they are taking, especially in the cities like metropolitan cities, or those are working, but there are so many people are in the urban rural area where they cannot they don't have an awareness of these type of health insurance, even though government is giving some type of health insurance to them. So this financial burden is also a big issue. And like urban and rural division, as we said, urban and rural's different things. So those are working, living in a rural areas, they have an access to the healthcare is a little difficult, and accessibility and their affordability and lack of services. They don't have a proper clinics in their area, and diagnosing at the late stages. And even they start the treatment, sometimes they go to the different hospitals, even if it is away, but the continuation of treatment, the follow-up of treatment is a problem. As we know, cancer is a chronic problem. Maybe a mother who had a mastectomy and she feels that she is okay now, but she has to go for a regular check, and follow-up is important. So sometimes when they start missing, slowly it will go to a lung cancer, and maybe a bone cancer, the spreading will be there. So not just a mastectomy is a complete treatment for them. So they need to have a follow-up too. So that is also a problem when they are in a rural area. So they don't get an equitable access like how an urban area is getting. Less chance to participate in clinical trials because these are the researchers that they can undergo. Anyway, that we will see again a clinical trials little detail. Infrastructure. So mainly primary health center. As I have told, basic care services is a primary health center. Without any spending any money, they can go to the primary health center and get the treatment. But in our primary health centers, the basic care services they may do, but not exactly related to the cancer aspect. So lack access to the specialist and diagnostic facilities, and it increases increases the risk of like misidentification of the problem or inappropriate treatment regimen. Sometimes when they suspect some problem, immediately we cannot tell you have a cancer. So they will refer these particular patients to another area, but they will tell, give me some medicine today. So they will get a medicine and they will not come back to the primary health center again. So they cannot again continue the treatment. So these are all the big challenges we are having related to the primary health centers. 70% of Indian population lives in rural area, but 95% of cancer centers is only in the urban centers. So see the difference. Population is more in the rural, but we have a facility only in the urban, that which is 30% of people where we live. So this is a major infrastructure issue. Lack of resources, as we know, cancer can be treated with the chemotherapeutic drugs, especially the drugs like doxorubicin and cisplatin, or any other innovative medications or anti-cancerous treatment. So those treatments have very, very low availability, limited availability. And even there is a statistic like 43% of the public hospital pharmacies have some type of a cancer medicines, and 71% in private hospital. Even private hospital pharmacy is having a lack of resources. So this is the percentage. It should be 100%. That's what we expect. Then only the treatment cost will come down. But the availability of medicines are very less. And there is a report like from WHO. They say India requires approximately 1,350 linear accelerator machines to meet the patient needs because the growth of cancer incidence is very high. But we had, like this is in statistics on 2022, only 365. Only 365 linear accelerators. So see the difference. So people have to wait for this linear accelerators. They have to have a long queue time to get their treatment. So with that, automatically their progress is very high. Similar way, like there is a 50% of these facilities are in private cancer centers. Like we have a resource person in from HCG, they may be having like will give a detailed information about the quality of care what they provide, but it is a private cancer center. So the people have to go to a specialty cancer centers to have a treatment. So that is another problem. And the consequence of these deficits, as I told, they have to wait for a long time, long queue time. 1 year, some people are waiting for 1 year to have a radiotherapy. So definitely by the time this cancer will reach to their end stage. So this is a big concern in our country. And oncology workforce related to our physicians or nurses, whomever is working, it is very, very less. Already we have a shortage of medical infrastructure, that is workforce. Along with that, again, oncology, again, it is very low. So 1 by 1 million population, we have very, it is a statistics which is given in the India and abroad. So it is very less medical oncologists we have. So this is again leading to a prolonged waiting time for the patient, and everyone is like, no, the time between the doctor and the patient interaction is getting reduced. So they cannot ask so many questions to them. So quickly they have to finish their thing and come out and see the next patient like that. So that difficulties are there. The workforce is very less. And shortage of healthcare professionals like chemotherapy pharmacists or those are administering the medicines to them. Again, they are less. Their number is very less. So we cannot provide a high quality cancer treatment. And these factors definitely involving medical people to even they are not taking part in clinical research, because with the clinical research, they can identify more solutions for the problems. So that is also not happening. In fact, like 70% of the work time is allotted to the clinical duties. So they are not focusing on much of research. So with that thing, again, there are not much researches are happening to reduce the cost of care or how to improve the infrastructure. What are the problems the patients are facing like that? So this is one of the scope area where we have to do a lot of clinical trials, which can improve the scope or like the improvement for the patient conditions. Cost of care in other countries, like it is like US, UK or Saudi Arabia, like it is little less because they are not going to take it from their packet and going to give. It is their insurance. The government is paying an insurance. Because of that, it is less expensive. But for us, it is really a big burden for our each community members. The cost is extremely higher than their annual income. Like it is, they say like 32 to 65% of average annual income is taken by the cancer treatment. So it is very difficult, and we have only a 20%, even less than 20% of Indian people is like having an insurance coverage for any type of a treatment. And patients have to take the money from their packet, and there are so many incidences we can hear, like they sell the house and take a treatment, they sell the land and take the treatment. Even after the treatment, the survival rate is very less like that. So many like incidents, even our nearby people, when they say, we would have heard it. So the cost of care is very, very important. And even though they take some insurance or something for or like a loan or something and taking a treatment, the reimbursement, again, it takes a long time. That causes a stress for them. So the financial burden is a big issue in the Indian community. Lack of clinical trials, as I said, there is very less clinical trials. And in India, even the clinical trials, like if we say 2014 to 17, like 694, like phase 3 cancer clinical trials are published. Only 8% are under the low middle income countries. In that, again, India will have a very less percentage. So that is one thing. And 7 to 2017, only 350 interventional cancer trials are registered in CTRI. So like nowadays, whatever research we are doing, we are registering in CTRI. So this is related to a cancer, that is an interventional cancer trial, only 350. This is a very, very low number. So I didn't get any statistics after 2017. Maybe it is increasing now, but this is a very poor number. But if you see 2017 in USA, 2066 interventional cancer trials they have registered. But the cancer incidence in US and India, when we compare, we are like very high, 30% increased. But we are not doing much clinical trials. So that is another concern. And landscape of clinical trials, even when they are doing a clinical trials, when they try to segregate which area is doing a more clinical trials, they say urban cancer centers. But the cancer incidence is very high in rural areas like Delhi, Maharashtra, Chandigarh, and Puducherry. So these are all the area. There are some cancer researches are going on, maybe Bangalore, but the highest incident rates are in Northeast Asia. But there are no much trials or studies are happening in those areas. So this is like a discrepancy. Again, whatever the results they are publishing, it may be again to the particular area. So whatever the research results which is coming in Puducherry may not be fitting with the Northeast India. So they have to do a lot of research related to their gender, related to their community, related to, because it is one thing related with a tradition, like genetic factor is also one of the risk factor for a cancer. So location wise also research to be done. So oncology training programs in India do not offer a structured training in clinical trial methodology and GCP, good clinical practice, or drug development. So we are still lacking. So we are looking for other countries to give us medicines. So the cost of care is also very high. So what are the barriers related to vaccination? So lack of HPV awareness with the general public is a big concern. And there is a lack of provider of recommendation, concerns about HPV vaccine, and difficulty in completing the doses. Like we have, as I told, like 2 doses, there is a 3 doses series also. So they may take only one and second dose is not taken. Like that, they may miss. So that is also one of the barrier. Because HPV vaccination is little worldwide proved related to the cervical cancer prevention. So we are not taking these vaccination. But nowadays in the private hospitals, they are saying like you have to take a vaccination at the age of like that adolescent period. There are few mothers, like even one of my friend was asking, have you given a vaccination to your daughter? But I was not willing to give a vaccination. Again, it is a barrier. Maybe because of COVID incidents, no, the related to vaccination, each one have their own thought, like whether to take a vaccine because it's a viral infection again. So let us wait. So like that, we have a lot of barriers, including me, a barrier to take a vaccination. So what are the potential solutions? As we saw, the different barriers, ineffective team and inadequate resource. This is the main reason we have seen before. So what are the solutions we have? Definitely, we need to have a MDT coordinator, like multiple team. The team has to work together, starting from a PHC till the specialist. And the electronic informations we need to move. Nowadays, slowly we are moving to an electronic health records. The government is even the digital health is a big focus of government of India. So these informations, when it is getting transferred, it is little easy to transfer information from one area to another area, even a telemedicine. So these are all the things which can be helpful for the people. And joint protocols, government has to create a lot of protocols and agreement between, they are doing a lot of job, but it should reach to the lower people too. And inadequate resources, as I told, telemedicine and regional cancer center network, all those things will be helpful. Maybe the next poster I can explain to you. So as we have seen different barrier, there is management also. So lack of awareness, how do we manage this? Community awareness program, as like as students or hospital employees, we will conduct a lot of community awareness programs. So that will be helpful. The public will be getting an idea about what is cervical cancer, how to identify a breast cancer, how to do a testicular self-examination. These all will be very helpful, and screening can be done in schools and media campaigns. So this is helpful to reduce or improve the awareness for the public. And financial constraints, the government has to give a universal health coverage. So subsidies for them, and definitely a non-governmental organization should help these people, like those are having a financial issues. So, and early detection, definitely early detection will reduce the cost. compare with going to the second, third stage and the fourth stage. So that is one important thing. Limited infrastructure, as we have told the primary health center, another thing. So how can we manage it? Regional health centers. We can create a lot of regional health centers. So different locations, like maybe within 3 or 4 or 5 villages or 10 villages, in that one regional cancer center also. So they will communicate to this cancer center. It can be communicated to the tertiary cancer center, something like that. So the identification will be quick, and mobile screening units, like Ms. Uma said, there is a mobile screening risk factor assessment by some 2 doctors related to a breast cancer. Definitely, it is all will be very, very helpful. Like that, so many researchers, like these all even comes under a clinical trials. So that will be helpful, even though we have a limited infrastructure. Workforce shortage. So the nurses who are trained can be maybe a registered nurse can be trained for this oncology programs. And today we are all of us are sitting here to understand what is cancer and what is the issue, and the continuous professional development. Definitely, it will be improving. We now I don't know how many of you are there, like around 50 and 60 people. So we 60 people should communicate to the other group, at least to our family member. Definitely, it is going to help for 60 family to understand, or at least the early identification of a cancer. So that is something very important. And fragmented care and delayed issues, as we told, the navigation system, standard treatment protocols should be there. Like how we have a standard protocol for each and every medical illnesses. Similar way for cancer also, a protocol should be very clear. So cancer registry or multidisciplinary team boards, all those things, these all are happening in the private sectors like tertiary care hospitals, but it should come to the base root level too. And cultural and psychological barriers. When one with a stigma, we need to be careful. We should accept, we should say that it is not a big problem, because people say it happens because of my sin or something. Because any health issues, it comes immediately, they say, I did, what did I do? What sin I did? Why I get this problem? Because cancer is already stigmatized. So their psychological issues also will be there. So we need to try to talk to them. And even the palliative care is another problem, like long term, the way when they are sick, they need a palliative care or a hospice services. So home-based models can be created. So in this aspects also, there are a lot of researches we can do it to improve even the long-term cancer patients. So these are all the different things which can be helpful. And as we all, what we can do, it's just like a conclusion. So knowledge, awareness, and understanding is something very, very important. So share the accurate information about the cancer, deal with the misconceptions, like it is treatable. Anyone says it can be manageable, like that positive word we can tell, so they can go and have a check with them and reduce the fear about the cancer. The same thing, negative feeling, negative belief, negative attitude, don't share. Make them positively tell them to go and do a early identification or detection. And use the voice, like wherever there is a fear or stigma, we need to talk, because we are the healthcare professionals. We need to talk to them and help them to understand the problem. And government, community, employers, media, everyone have to work together. That's what we told, multidisciplinary team. Even social media, it plays a vital role nowadays, because related to so many things, people are with the Instagram and different reels and other things. So we can use these media. Even Nurseslab has created one shorts recently, I saw. So they were giving a lot of information related to AI and identification of MI, something like that. So even you can also initiate something related to this cancer aspects. So these videos will be helpful for public to understand how can we have an early identification with the symptoms. So these are all the different references which I have used. So thank you so much for the participants, for the patient listening. And I hope I have shared some of my experience and the understanding what I had. Hope it was a clear session for you. Thank you, everyone.
Thank you, ma'am, so much for the detailed presentation on the barriers of nursing and in cancer care, especially. We will move on to the part 3 of our webinar. The third speaker for this evening is Mr. Karthik Sellappan, Chief of Nursing, HCG Hospitals, KR Unit, Bangalore. Mr. Karthik holds a master degree in nursing specialization in psychiatric nursing and over 14 years of progressive experience in nursing leadership and healthcare quality. He has been awarded with multiple recognitions for leadership and quality implementation, with a strong expertise in nursing administration, policy development, and simulation based competency driven training. The topic of presentation for today, sir's topic is supportive care in oncology, managing symptoms, and improving quality of life. We are honored to have you with us today, sir. Over to you.
So, very good evening once again to all the participants. This is Karthik. Today, I'm going to talk about supportive care in oncology, managing symptoms, and improving quality of life. So, before that, I would like to thank my previous, presenters who are joining with me for a wonderful evening, who have given for a wonderful, that management, identifying that early signs of cancer as well as that barriers in that patients to going forward to take the treatment is very easier now. So even though yes, whatever barriers are there, and then if it is delayed for diagnosing for cancers, it would be difficult to treat the patients completely. So that is why the support carries plays an important role in cancer setup. So today I'm going to deal about that managing symptoms and improving quality of life in an oncology setup. So whenever we talk about cancer treatment, we often focus on chemotherapy, immunotherapy, or hormonal therapies, surgeries, and radiations. However, cancer is not only about curing the diseases; it is all about that how the patients live during treatment and beyond. So the supportive therapies always ensure that the patients remain comfortable, maintain their dignities during the course of treatment, and also tolerating the treatment better and better, and also that providing for the quality of life. And this supportive care, it starts at the time now at the time of the diagnosis of a cancer. The main objectives of today's session is understand the concept of supportive care in oncology, identifying common symptoms experienced by the cancer patients, discuss evidence-based symptom management strategies, and also recognize the role of multidisciplinary team, and understand the impact of supportive care on outcomes. Then coming to the point of principles of supportive care. And before talking about that principles of supportive care, we also understand about the difference between supportive care and palliative care and end of life care. So end of life care, it begins at the time of end stages of cancer. So when there is no any options, when the treatment doesn't work for the patients, then they have to opt for the end of life care. And then palliative care, so in between course of treatment, the patients or family members or collectively the people decide to go about on a supportive care. So where that that again that patients and family members, everybody is involved, and collectively they will be taken care of the decision. And when I'm talking about that supportive care, so we have already discussed about that it begins at the time of diagnosing of the cancer, which means it starts at the time of diagnosis and it ends at the time of course of treatment, which means that entire life cycle the supportive care will be continuing with the patients. So supportive care mainly aims to maintain a quality of life to the patient, and also the people who are diagnosed with the cancer, it helps to achieve maximum benefit from their treatment. And also like it is involved for that multidisciplinary team, where that it is a person centric and also patient centric, and then they will also using for the holistic approach and during the course of the treatment. And then when we are coming into this particular model, so this model explains about the patient's quality of life influenced by the individual of characteristics and also the environmental characteristics. So when we are talking about that character of the individual, it also talk about that age of the person, gender, education, and coping ability, beliefs, values, and then comorbidities. When it is come to the environment, so environment also we have to think about that family support, financial condition, workplaces, cultural background, and then healthcare access, and then healthcare environment. So these two factors, influencing the five core domains. For example, one is the biological function. So biological function, what is refers to the person's symptoms and diseases what they are having, and then organ functions. Okay, so the cancers, you know very well about that, it's tend to spread one place to another places if at all it is not controlled, or if it is not treated properly. So also that whenever we are giving or providing for any kind of chemotherapy, it has their own side effects. So it is more important that, so whenever I know the patients are in a these domains, when we are talking about, it is more important to the nurses to focus on that, how to get rid of the symptoms, or how to get rid of the particular, or the patients to cope up the particular issues. So main nursing roles in biological functions domain, so monitor vital signs, and also to check for the lab parameters every time whenever the patients get admitted, and early identification of the complication related symptoms, and preventing infections. And whenever we are administering the medication, we should administer in safe manner. And symptoms, so when we are talking about the symptom, the most common symptoms of the patient due to the disease or the illness, or during the course of the chemotherapy, so pain, fatigue, anxiety, nausea, vomiting, which are more common, so which we are going to talk about little more in detail coming slides. And next, functional slides. So functional status, so it is more important that the it would affect for always that person's level of confidentiality. Why? Because the persons always worry about that ADL, activity of daily living, and also whether the patient always think about, I can walk, I can breathe, I can do my activities independently, so whether I can able to continue my work or not. So that we have to make sure about that, and we have to encourage the patients that yes, you can able to do for your activity of daily living. And also we have to encourage the patient to socialize more and more. If at all, yes, if you are the patient is doing well, we can encourage them to go back and then start work as like for the routine person. And then general health perception, so the general health perception, always these people are thinking about that, whether this treatment is going to work or not, whether my tumor will be the size will be decreasing or increasing, whether the treatment works or not. So the people are always having that the conception about that, in the aspect of the cure. So that yes, it is important that we have to build the trust of the patients, we have to make them to psychologically more comfortable about their treatment, and also it which going to help them to proceed for the normal day-to-day life. And then overall quality of life, so here that overall quality of life, that always we have to focusing on physical, emotional, social, and then spiritual well-being. So here also, so these all five domains, the nurses roles are very 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 important, that if at all, if any one domains are affecting, again which would affect for the entire outcome of the patients. So what is supportive care in oncology? So main agenda of that supportive care is prevention and management of symptoms and side effect of the cancer and its treatments. So mainly these supportive care addresses for the patient's physical symptoms, psychological distress, nutritional needs, social issues, and then spiritual concerns. The main aim of the supportive care in oncology, it improves, yes, quality of the life of the patient, reduce the treatment interruptions, enhancing the patient satisfaction, and also increasing the survival rate of the patients. So these are the five domains which plays important role in supportive care: physical, psychological, nutritional, social, and spiritual. So neglect any one of the domain worsens outcome of the patients. For example, physical, yes, if at all, if the patient is not treated properly, so that if the symptom is not managed well for pain or fatigue or nausea or infection, definitely the patients leads to it would lead for that dissatisfaction of the patients, may discontinue the treatment. If it is continuous, if it is not managed well for about the pain, which brings for psychologically the patient that that unbearable pain, that to focus, not to focus on the treatment, to proceed for some other kind of treatment. So then which leads to develop for psychological related symptoms like anxiety, depression, and fear. The same way that nutritional, social, and spiritual, every domains are having a different perspective view. So if we have to manage for all five domains, if any one domains if reflected, that definitely bring for that worsen outcomes in the patient's life. So here, cancer related treatment cause a heavy symptoms. The most common symptoms are pain, fatigue, nausea, mucositis, anxiety, and malnutrition. So if you are not managing these all, leads to a treatment delays, which means that the patients may not turn up to the treatment to continuation. And yes, if again, if it is not managed well, again it increasing the hospital admissions, or it is increasing the length of stay of the patient, which brings, yes, psychological distress, and also poor adherence of the treatment facility, and also it might reduce the survival rate of the patients. And first one is pain management. Yes, of course, which is the first and foremost things to be managed for the cancer patients. Why? Because of that, the pain, the patient who feels that it is unbearable and unexplained as well. So always there will be a different types of pain, like surgical pain and other related pains, and then cancer related pain. So cancer related pain, again, that because because that whenever the tumors increases, the tumors, like it compress, okay, it's be putting more pressure on your vessels or muscles or nerves or in the bones, which create for that more pain. That is for the continuous pain. So that is why that and even like whenever the patients are undergoing for either any radiation therapy or like chemotherapy, again that also would cause for some amount of the pain to the patients. So that is why the pain plays an important role in a cancer patients. Okay, so again, yes, we do have a many strategies to assess and reassess the patient pain. And yes, for example, graphic rating scale, and numeric pain scale, and also like WHO pain ladder scale. Okay, so these are helping to understand about how the pain, okay, so what score it is for the patient. So depends upon the score only we are deciding about the pain management. Okay, so that regular assessment of pain assessment and reassessment important when it is the patients come to the hospital. And also, yes, like the WHO pain ladder, which is going to help us many oncology setup to controlling and then managing the pain management. So here they have given for step 1, step 2, step 3, and step 4, 4 steps where we need to how to control for the patient's pain. And here it is for ascending and then descending order. So either you can you know start with mild pain to severe pain, or from the severe pain to mild pain. Okay, so here step 1, that is explained about that non-opioids analgesics, NSAIDs, for example for paracetamol. Step 2 for weak opioids, you can give an example for tramadol. And step 3 for the strong opioids, and like transdermal patches, like for example morphine, fentanyl patches, and then injection fentanyl also. And then step 4 that we can use for that nerve block or epidural infusion or PCA pump to control for the patient's pain. So here, that whichever like the patient's severity of the symptom, the symptomatic management will start from either from that step 3, step 2, and step 1, or step 1, step 2, step 3. So when it is uncontrolled or unbearable, if the patient is hospitalized, then we can go for an option 4 to control for the patient's pain. Next, physical management. Yes, it is cancer related fatigue. The most common symptoms of chemotherapy patients, or the persons who are on treatment. Again, that fatigue also may be in related to the condition of the patients. So if it is related to for a low HB, then there's a treatment, treat the anemia. If it is related to the patients, uh, like fluid and electrolyte imbalances, and then replacing for the fluids, or it is related to the any of the patient activities or psychological stress, again the symptoms will fall under based on the symptoms. And another important thing is nausea and vomiting, and followed by pain, which is the another most important thing which we need to be carry out. So we know very well about that anatomy and physiology, and then control system of that nausea and vomiting in our body. So that whenever that triggering factors come, that here that will inducing the nausea and vomiting for the chemotherapy patient. So that is why, so the American Society of Oncology has the guidelines of prevention of chemotherapy induced nausea and vomiting. So main causes for that chemotherapy radiation are the patient's psychological distress, for example anxiety, which can leads to develop further nausea or vomiting. So the management, yes, prophylactic antiemetics, hydration, dietetic modification, and scheduled medication. So here we do have for that American Society of Oncology the guidelines. So like here we according to the severity of the vomiting, Okay, so like it's minimal, low, moderate, and then high. Again, that it will be considered about how to manage for the day 1, day 2, day 3, and day 4, and then optional of that is what are the medications to be used for it. Okay, so the preferably that minimal, there is no any routine prophylaxis to be used. Maximum it will be controlled by the non-medical management. So when it is low, that we have dexamethasone is the first line preferable options. And then when it is a moderate, yes, the 5-HT3 receptor antagonist, dexamethasone please preparant for anthracycline and cyclophosphamide combinations. And if it is high, then they will go with the 5-HT3 receptor antagonist plus dexamethasone plus aprepitant. Okay, so these are for the day 1, like when it is mild, moderate, severe, or it is low, minimal. So however it is depends upon the severity of the symptom, the treatment will be decided. Same like yes, we have that day 2 delayed emesis, and then day 3 and the day 4. And next one is the oral complications. Yes, the oral complications in according to the studies, 40% of the patients receiving chemotherapy or any malignancy, the patients will experience is the oral related complications. The acute and then long term side effects are the taste loss, mucositis, and then candidiasis, dry mouth, and radiation also that radiation related carries trismus, and then tissue breakdown, which bring for the delayed healing. So these are the much more common side effects, or the acute side effects and then long side effects of the chemotherapy and then radiation therapy, oral related complications. So the main management, yes, oral hygiene protocol, pain control, and then early reduction. So which means whenever the patients gets admitted into the hospital, it is important how do we do for a physical initial assessment for the patients in all the systems. So the same way we have to check for the patients oral care, oral care, that oral hygiene as well. Psychological support, yes, of course, that one another most important thing, that if at all if you are not supporting, or if you are not managing well, so which can leads to develop for the patients anxiety, depressions, and then other body related concerns. So the most important thing is like whenever the patients admits, we have to screening the patient's level of confidence, whether the patient is low or high. And also it is important that to sit with the multiple counseling with the patients along with the family members, and honest and then open communications that what are the treatment as planned for the patients. So there is no any hide and seek here, that so we should always be transparent to conveying to the patients, like how the therapy is going to help, and then what are the improvement we can see, and what are the possible side effects, so that the patients also psychologically prepared, and also so then they will ready to face. And family involvement, it is another important thing in the treatment. Nutrition supports, yes, whenever there is nutrition comes down, that intake comes down, that possibility of increasing the infection rate to the patient. Yeah, because most of the patients are already treatment related immunocompromised, and then which would affect for that treatment, that increases the toxicity and also increases the chance of mortality. So interventions, again, early screening, and then refer to the dietitians to plan accordingly to the patients what type of chemo they are getting, and what is the current stages of weight, and then what need to have that the patient micro and macronutrients. And yes, of course, if a high protein diet should be planned, and supplements need to be planned for according to the investigation and also the patient's current nutritional status. Social and spiritual supports, yes, the patients always there in that hopelessness in their life, as well as for that work. So that always we make sure about that the patient should come back, and then stay in positive during the course of the treatment. So like we have to provide meaningful life for the patient to bring back their hope, and also we have to make the patient to accept what the current illness and then treatment strategies. Multidisciplinary team, yes, of course, they are playing a important role in oncology sector. Just I wanted to give an example in my own hospital, that how the multidisciplinary team functions. So these are like oncologists, oncology nurse, palliative care specialist, dietitian, psychologist, social worker, physiotherapists, and then other special care providers. So these all work together. Once if the patient registered for any type of treatment, and then mean further if they diagnose with the oncology, or if the patients newly come into the hospital, so then they will meet into the oncology, they will analyzing for the complete patients, patient follow which what are the investigations, if they have that any details in hand, or else after the investigations they will be deciding about that what to go, what are the plan, treating based on the diagnosis. So here, like, once the diagnosis is done, so we do have for that, tumor board meeting for weekly once. So this particular tumor board meeting will help for that, deciding about the patient's treatment, if at all it is critical, more in critical. So that collectively, like, all 24 hospitals, the doctors are coming together and then joining in virtually, and also they will be discussing about that what are challenges are they having of the particular patient. So if everything is decided and planned, and then collectively they will be taken treatment protocol, to make sure about that which is going to benefit for the patients to add on life, add on life for that in during the course of treatment. So that they will be taking care of that every single step with the expertise opinion. So once it is decided, then it will then given advice for the patients, IP patients. So I'm talking about both the IP patient and the OP patient. So if already IP patient, then that will be carried out. If it is OP patients, then that will be decided to when to start for the treatment. And second thing is oncology nurse. Yes, once the nurse receiving the patient into the department, her responsibility to inform to the multidisciplinary team that who are involving for the patient's care admission to till discharge. So palliative care specialist who comes into the picture, and then who always make sure about it that pain management and other related chemo related other pain and related symptom management. Dietitian, yes, they plan for about the nutritional status. Psychological, they will come and then they will talk about the check about that level of the patient understanding of the nature of diseases. If the patients have more fearful and they worried and then they lost hope, then definitely they will sit with the family members. They will make sure about that, bring back the confidence from the patients. Social worker, yes, they are another one important persons, they who can always have a bridge between that patients and family members and then organization. They never ever miss out the patient's treatment continuation. They always connect with the patient and then family members, and they give a reminder to the patients who when to come for the next visit, OPD visit or IPD or the chemotherapy. Always they have a connect. Alongside that, one more thing, if any patients are financially are affordable, and also they are trying to connect with some of the government or agencies to creating the fund for that continuation of the treatment. Physiotherapists, yes, they are helping for that ADL of the patients. And spiritual care, yes, of course, that they will be coming and then they're providing the meaningful life to the patients. So these are the tools which we are using for the patients, like when the patients are met with all that multidisciplinary team at the time of discharge, or 1 or 2 days early, then we used to talk to the patients and we check with the this questionnaire is that how the patients are before and after treatment, how do they feel about it. So for example, like here, so for example, physical aspects, you can select any one of the questions. Okay, so for example, did you feel any difficulty walking even or short distance? So before that very much, now it is often. So were you able to talk or bath by yourself? Not at all, now sometimes. So when the patients are telling about yes sometimes, that is the outcome of the particular treatment things. And same like emotional aspect, like so whenever the patients are saying that how do you feel, then some I feel sometimes feel good, sometimes I'm not bad. So when the patient's feeling good, yes, usually. Do you have a good update? Sometimes or usually. So social aspects, did you get any encouragement? Very much or very much. Again, similarly, it is same that it depends upon that whether the patient says sometimes or not at all or very much or often. So based on that, we will be giving a scoring, so that when the score is goes out of that much meeting that patients. So we always make sure have very happy about that patient outcome. Again, still if the patients have not meeting that score, if it is a less, again that what we will learn that we plan to go for in one more setting and to sit with the patients and also for the family members and also along with the multidisciplinary team, to make sure about that the patient should gain the confidence level before getting discharged, and also to prepare for the next treatment, chemo or other related to this treatment strategies, like either they when they come for radiation therapy or chemotherapy or any surgical procedure. So we make sure about that to prepare the patients before discharge from the hospital. Yes, so I'm coming to the last slide. In oncology, cure is not always possible, but comfort, dignity, and quality of life always are. Okay, so the most important thing is we should not neglect whenever you feel something is goes into your body. So it may not be a cancer, it may be a cancer as well. So what we need to create an awareness either to our health sector or that society or in a family members. It is more important that whatever symptoms it is exhibiting from our body, so that maybe we have to immediately to go and check with a doctor. And if it is related to cancer, we should not go for that any small hospitals. We have to go to the dedicated centers where they are providing for the complete accessibility to diagnose and then treat for the cancer. So prevention is always better than cure. Once again, thanks everyone.
Thank you, sir, for the wonderful presentation. It was definitely an eye opener for all of us here. I would like to thank all the speakers for this evening, Mrs. Umavali, Dr. Puvaneshwari, and last but not least, Mr. Karthik, for all your time and effort put towards this webinar and to be a part of Nurses Labs. Thank you to all the participants who are present here with us today for registering for this event. Kindly do subscribe to all our online platforms and do visit our YouTube channel and subscribe for more updates. Thank you and have a good evening to all. Happy learning.